I like to start with just a little bit about me for those of you who I haven't had the pleasure to meet. I was born in Austin, Minnesota. I spent about 10 years in Minneapolis, going to school at the University of Minnesota, and then residency, which is kind of like an apprenticeship for medicine, was at Ohio State for 5 years, and then I moved here in 2013. And I live in town. I've been here since that time. That's my family, my 3 boys, my wife. I'm going to talk about these 5 main points. So I'll go over the prevalence of stones, how we go about diagnosing stones, risk factors for patients in terms of development of stones, prevention, and then finally treatment. Obviously, if we're good at prevention, we can hopefully avoid treatment, but there are certainly some patients where, prevention may mean, instead of 2 stones in a year, we hopefully get it to 1 in a year. So it's about decreasing frequency. Kidney stone prevalence, it's increasing with time. The lifetime risk is more likely in men than women, but the overall percentages are quite high. 1 in 10 women, 1 in 5 men. The symptoms are quite variable. I've had patients show up who, we may get a CT scan for some other reason and incidentally find out that there's an obstructed kidney from a stone that's in the tube going from the kidney to the bladder. I'll show you some anatomy later to explain what I mean by that. They don't have a whole lot of symptoms. And then on the flip side, I may see a patient who comes into clinic with severe flank pain. They're literally laying in the fetal position on the exam table with the worst pain of their entire life. And trying to reconcile the differences between presentations is challenging. I don't know exactly why it's so painful for some patients, and in a minority of patients, it's as if they really aren't even aware they have it. Pain of the side where the kidney is, blood in the urine can sometimes be present. In terms of labs, we may find blood in the urine microscopically if we're not able to see it visually. It's really important at that time that we check for infection as well when we collect the urine. In terms of imaging, typically it's CT scan. Ultrasound can be quite helpful as well, and that avoids the downsides of CT scans, the radiation exposure, and it's a cheaper study. It just doesn't give quite as much information. The way I typically run into the situation is the diagnosis is usually made. I usually see patients as referrals, so they may have presented to the emergency department with some or all of those symptoms. They ultimately undergo some imaging, like a CT scan, and stone is identified, and the plan is to follow up with me if we can control the pain with some oral medication and get the patient home. Otherwise, the patient may need to be admitted into the hospital for pain management, and then I can see them in the hospital. So it's one of those 2 pathways. This is the urinary tract. So as a urologist, this is kind of my main area. Anything that touches urine, basically. So the kidneys make urine from blood. Blood flow through the kidneys. The urine drains into these little fingers here, ultimately into the renal pelvis, and then down the tube and into the bladder. This is an example of a CT scan. So this patient is lying on his or her back. This is the spine, so white is bone. These are cross sections of rib. This is intestine and fat in the belly. This dark stuff's fat. This is muscle. And these are the kidneys, here and here. And stone shows up as white. So the diagnosis isn't always all that challenging. It's really the prevention and treatment is the much more challenging area. But as you can see, this patient has a small stone in the kidney. That correlates on this imaging kind of tucked away up in this area. That kind of a stone is often not symptomatic. That type of a stone is often not painful at all. And the reason is that stones are painful because of what they do to the body, not just being present, but actually obstructing the flow of urine. So the stones become symptomatic when they start entering this tube from here until they get into the bladder. So if they're anywhere along this tube, the stone will plug up the flow of urine. The kidney doesn't know to stop making urine, so it continues to make urine. The flow is obstructed. The urine builds up, and the kidney starts to stretch and dilate. And it's that stretching that is actually the pain. It's not just the fact that the stone is sitting in the kidney. So these kidney stones in the kidney back here are oftentimes not symptomatic unless they're popping in and out of this location, temporarily obstructing and then popping out back into the kidney. Sometimes that'll happen, almost like a ball valve. And then anywhere along the tube, and then finally the most common place, which is the most difficult area to pass the stone, is right from the tube right into the bladder, the very last stop. I probably see 80% of the patients with symptomatic stones, painful stones, that's where the location of the stone is. The reason is, I kind of describe this area, it's like that valve at the back of a fishing boat that allows water out, but it doesn't allow water in. Everybody familiar with what I'm talking about? So there's like a little flat valve right there, and the reason for that is when your bladder squeezes when you're going to pee, you don't want urine to shoot up into the kidneys. You just want it to, there's 3 tubes connected to the bladder. You just want urine to go out the urethra, out the tube you're peeing through. So that flat valve prevents urine at the time of urination. When the pressure in the bladder goes up, it prevents urine from going up into the kidney. It just makes it difficult to pass the stone through that area. This is an example of a CT scan where a couple things I want to point out. So this is where the stone is just entering that tube. So this is probably a symptomatic stone in the majority of patients. That's actually not in the kidney anymore. That's in that tube that goes right out off of the kidney and down into the bladder. If you take a look at these 2 kidneys, you can tell that this kidney looks different than this one. And that's because of the central part. That's backup of urine. So the urine is collecting in the kidney and is starting to stretch, and the patient's probably got pretty severe pain from that. So the stone is going to be, that stone is somewhere like right about here. This is an example of a patient with a really large stone. This is a patient that presented a couple months ago that I ended up taking care of. This is the type of stone that clearly will never pass. The tube is much too small for something that large to pass through. So risk factors for stones, only a few of these things we can affect. Many of these things we can't. Certain anatomic differences amongst us can lead to stones. Various abnormalities in the kidney and the way it develops can create an area of urine that doesn't flow very well, and that can lead to stones. Dietary, that's the main one that we can affect. Fluid intake is kind of our primary tool and one of the more important things to focus on for prevention. It's also one of the things that can lead to the formation of stones if if our intake is low. As we get older, our bladder starts to misbehave. We start to go to the bathroom more frequently. Subconsciously or even consciously, a lot of us will stop drinking as much fluid as we used to because we're concerned about going to the bathroom all the time. So I see stones in experienced folks, I'll say experienced or older folks, a little with increasing frequency because of that unfortunate cycle. Metabolic, body processing issues, that's, there's a few diagnoses that hyperparathyroidism, the parathyroid gland, or a few paired glands right next to the thyroid. And the parathyroid gland regulates calcium in the body, and occasionally a patient can develop a problem where that gland doesn't respond to the normal feedback loop in the body to check and balance calcium management. And it works overtime, and it doesn't listen to the body when the calcium level's high, so it continues to increase and increase and increase the level of the calcium in the blood, and when that happens, you end up with a lot of calcium in the urine. A lot of calcium in the urine will lead to more stones. Medications, there's a few that can lead to stone formation. High doses of vitamin C. Vitamin C gets converted to something called oxalate in the liver, and oxalate is one of the biggest enemies of a stone former. Oxalate is the dance partner with calcium. So when you have a calcium-based stone, it's actually calcium oxalate many times. So oxalate's just as important as calcium. So those high doses of vitamin C I always recommend against. Lasix can lead to some stones. The problem with that is we don't have a lot of alternatives. If you need to be on Lasix for fluid management, we don't have a lot of good alternatives to replace it. And Topamax is a medication I see many, classically, it's kind of a middle-aged female with chronic migraines who's on that medication to help prevent the migraines long-term. That can lead to stone formation. So when I see a patient with a stone, or if I treat a stone, or they tell me they've had stones and they want to know how to prevent them, I really basically explain that there's two ways we can go about it. And let the patient help me decide which way they want to go. So the first way is I give them generic recommendations. Generic recommendations is kind of like getting a suit or a dress off the shelf. It's not a custom-made, tailored suit. It's a lot quicker. The information is not as tailored to the patient specifically, but it's a lot quicker and cheaper. The patient-specific workup is the other option, and that's basically getting a tailored suit or a tailored dress. It's undergoing blood labs and urine testing to identify the biggest risk factor or risk factors that that specific patient has, and then trying to figure out ways to reduce the risks. The urine is actually a 24-hour collection, so you have to be around the house for 24 hours to collect all the urine. And then there's a company that I use actually where the urine gets sent back to the company. They send all of the pre-labeled labels and whatnot, and then when I get the results, then I see the patient back. We go over the results. So the question is, don't oranges have vitamin C? And the answer is yes, they do. But the amount of vitamin C in a daily amount of orange or orange juice is not a significant amount to lead to stone formation. The vitamin C supplements, if you ever look on the back of the bottle, you'll see that some of these vitamin supplements, like vitamin C, will have like 1,000% of the recommended daily amount of vitamin C. So it would be like, I don't know the exact numbers, I'm gonna kind of make this up, but it'd be like eating 50 oranges or something like that. So the amount of vitamin C we can get in a tablet far exceeds what we need on a daily basis. And the trouble is when you take the tablets, because it's such a high dose. So vitamin C is fine in moderation, and it's a critical part of your diet. It's just if you vastly exceed the recommended amount is when you run into trouble. This is an example. Don't worry about the details on this. I'm just trying to show you an example of various disease states that patients can have that are unrelated to stones, but these disease states ultimately lead to stone formation. So it can get fairly complex, but the 24-hour urine testing helps kind of sort this out. This is what the 24-hour urine test result looks like. It doesn't show up very well, but the left side is green, the right side is red. The red numbers are high-risk components. The green numbers are low-risk components. So for instance, urine volume, the top line. The goal is to try to produce about 2.5 liters of urine a day. It's quite a bit. But if you're a stone former, it's certainly worth focusing on that because that's where the risk level of forming stones drops significantly. So this patient collected his or her urine and it was about 1.5 liters. So it's kind of a middle of the road number. Ideally we'd like to get it closer to 2.5, so I would recommend increasing fluid intake. What I hear a lot of times is, I drink a lot of fluids, but I don't make a lot of urine. And, what you drink ultimately becomes what you urinate, with the exception of, perspiration, so sweating. So if you're somebody who likes to play pickleball a lot, or jog, or use the Stairmaster or something like that, all of that perspiration is fluid that you're taking in that doesn't turn into urine. So in that circumstance, you have to drink even more. We lose a little bit through perspiration, about 1/2 liter a day. So 1/2 liter of fluids a day just goes into that. What we call insensible losses. Urine calcium, that's the number that shows how much calcium is in a patient's urine, and this is a nice good number, 64, that's terrific. Some patients are closer to 200, 300. Those are high numbers, and that's where we can talk about dietary changes that lead to lower calcium in the urine, and that mainly is through low salt diet. So whenever I say low salt diet to patients with stones, that's because the more salt you take in, your kidneys have to get rid of the salt, and unfortunately when the kidneys get rid of salt, the kidneys also get rid of calcium. The kidney can't separate the two. So high salt diet leads to high salt in the urine, which leads to high calcium in the urine, and the calcium is the issue. Oxalate's a really challenging component to decreasing your diet because it's found in so many different foods. I'm always excited when I see a patient's oxalate is low, because talking about a low oxalate diet to try to get that number down can be very challenging. Urinary citrate. So citrate's a good thing. We want high citrate levels. Citrate binds calcium and kind of hides it so that it can't form stones. We have a medication that we can prescribe to increase that if needed, in the form of potassium citrate. The problem is it causes a little bit of upset stomach. The tablets are large. Insurances don't always cover it. But we do have to check labs, so if I do prescribe it to a patient, we have to make sure we follow up and check potassium levels. This is an example, this is a superstar patient. This is actually from that patient's note. Of course, there's no patient identification here, so it's all okay, but I just wanted to show you an example of a patient that I met in 2014. This patient formed a couple stones. I think I treated one with ureteroscopy, and she was motivated to develop less stones, of course. So we did a 24-hour urine to try to identify her risk factors. So the urine volume was not bad. 2 liters is pretty good. It wasn't 2.5 liters, but it certainly wasn't 1 liter, which is a lot of times what I'll see. Urinary calcium was a little bit elevated, but not terrible, at low 200s. Urine oxalate was fairly high, in the 40s. Citrate was pretty good, about 1,000. So I counseled this patient on increasing her fluid intake and restricting her oxalate through diet. And I have a handout that I gave her and I showed all of the high oxalate foods, and she went through and made all the adjustments in her diet that she felt she should to try to decrease oxalate. And we did a follow-up 4 months later, and look at that, 4 liters. She went from 2 liters to 4 liters, so she doubled her fluid intake. That's great. Not everybody can do that. And I always warn patients, we want to increase your fluid for the long term. It's more of a marathon than a sprint. So we want to increase the fluid intake, but we want to do it in a way that we think is a reliable improvement that can happen for years, for the rest of your life, basically. And not everybody can get to 4 liters. I don't know that I could. The urine calcium, it was a little high. We didn't do much to change that, and it stayed at about the same level, but her urine oxalate dropped significantly down to basically an average of 20. So she cut her oxalate in half. She hasn't had a stone since, and it's been a real success story, and it's real exciting. This SS number, CaOX, is calcium oxalate. So that's like a number that reflects the likelihood that she would form a calcium oxalate stone, which is the most common stone. So it went from 11 to 2. So tremendous. The reason there's always 2 numbers is we do two collections so that we can average the numbers. There's a little fluctuation from day to day, so we average the numbers, we get a little bit better understanding of where you're at. So that's the workup in terms of prevention. Next, we'll talk about treatment. There's really 5 different things we can do when a patient has a stone. We can just leave alone. So if you remember that CT scan that I showed where there was a smaller, non-obstructing, asymptomatic, no symptoms stone, that's the type of a stone that we can just keep an eye on. If it's any larger, though, and patients travel internationally, or you're going to be in an area where there's not a lot of resources, then sometimes we'll go ahead and treat them, prior. Trial of passage, that's just trying to get a patient through an event. Where if it's a small enough stone where you can pass, providing some pain medication in enough time, hopefully it'll pass. The problem is how the degree of pain that a patient can have. Sometimes that can be a pretty challenging pathway. In terms of surgery, there's 3 different options: ureteroscopy, shockwave lithotripsy, and percutaneous nephrolithotomy. I'll go through the 3 of them. It rolls right off the tongue, right? I'll go through the three of them, and we have kind of an acronym for each one. So a trial of passage, is there anything that we can offer patients to help them pass the stone? In other words, maybe improve the conditions, maybe relax muscle so that that tube dilates. There's one medication called Flomax. If you asked, the urology community 15 years ago if it worked, they would have said yes. 10 years ago, they would have said no. 5 years ago, they would have said yes. And now currently, they would say no. So the problem is we continue to publish studies that have conflicting results. And we don't, if something like that works, you'd think you'd have reproducible studies. Each time we do it, we'd show a benefit. But the problem is we don't. So the jury's a little bit out on that, unfortunately. There's not a lot of downside with the medication. Taking it for a week or two, there are pretty minimal side effects, and it's generically available. So I certainly don't. I certainly think it's reasonable to give it a try. But typically when I see patients, they've already been in pain, they've been in the emergency room, and we're looking at typically, oftentimes needing to treat it because of the severity of pain. So starting with shockwave lithotripsy, this is a surgery that's performed in the operating room. It's for small to medium-sized stones. It's not effective for large stones. Deliver energy through the skin when the patient's asleep with X-ray targeting to send shock waves to the stone to break it up, to bust it up. Hopefully the fragments are small enough to pass. It's up to the patient to pass them. The advantage is there is no instrumentation in terms of going through the urinary channel. The downside is you're left with having to pass the fragments, and hopefully they're small enough to pass successfully. So the success rate's about 70% or so, lower than the other treatment options. This is one I don't do very often. I probably, do maybe 10 a year or something like that. This is what it looks like in the operating room. You can see the X-ray technology that's showing where the stone is located. And then there's this is the energy head here where it's right up against the skin, and the energy is being delivered to the stone in hopes of breaking it up. The next surgical option is ureteroscopy. This is what I do the most. It's again performed in the operating room with the patient asleep, so similar conditions. Again, it's for small to medium-sized stones. I use a telescope that's kind of like a black cord. The telescope's flexible, and I pass it up into the kidney. I can see the stone visually and break it up with a laser, and then pull the pieces out with a basket. And the success rate's much higher with this, but it does require instrumentation of the urinary channel. This is what the telescope looks like, so I can flex it, up or down, as you can see here. So I have a lot of mobility with that, and getting into the nooks and crannies of the kidney to try to identify all the stones, break them up, and pull them out. This is what it looks like during a case. This is the inside lining of the kidney. This is the stone. This is the laser. And it's breaking it up into smaller pieces. This is what one example of a basket looks like. It's a little wire mesh, then you push the little thumb activator and it opens it or closes it. And an assistant will run that while I'm running the scope, and we're trying to snare, these pieces. It gets to a point where you remove all the big ones and all the medium-sized ones, relatively. You get to a point where you're dealing with little 1 millimeter chips, and it's not really feasible to basket every single fragment. So a lot of times after surgeries, I always tell patients, I got all the big stone, all the big fragments, but there's always a little dust up there. So the question is, do I rough up the kidney? And so, if the laser hits the edge of the kidney, then it can cause some bleeding. That's not typically where the bleeding comes from. Typically, the bleeding comes from the equipment being passed up the tube, because the tube is a very delicate tube, and the equipment, it's passed in a delicate way, but the equipment's made out of plastic and metal. So I do have a video. So this is just the monitor that's up in the operating room, and this is the laser, and that's the stone. So that's probably a 1 centimeter stone, so about 1/3 of an inch, and laser's just breaking off pieces. The final option is percutaneous nephrolithotomy, and this is for large stones, 2 centimeters or larger. Again, it's performed in the operating room with the patient asleep. This surgery takes a little longer. It's performed with the patient on his or her stomach, so I have access to the back. The approach is for stones that are too large to be tackled with the equipment that I described earlier. The telescope works great, but you can only treat so much stone in a reasonable amount of time for a patient to be under anesthesia. In addition, during the process of breaking up the stone with the telescope, with bleeding, it doesn't take a whole lot for the visualization to be obscured to the point where you can't see what you're doing, and then you have to call it a case. This type of surgery is for that really large stone where you can't get at it with the little telescope, and you go directly into the kidney through the back. So I pass a needle into the kidney with the use of X-ray, and once the tip of the needle is in the collecting system where the urine is, then I pass a wire, dilate the tract to about the size of my thumb with a balloon, and then I put a sheath over the balloon, take the balloon out, and then at that point I've got a tract like a straw about the size, big around as my thumb, and that straw goes straight into the kidney, so I can get directly to treating the stones with much more robust equipment. This equipment that doesn't flex or bend like the telescope, but I don't need it to flex or bend because I'm directly in the kidney now. Patients stay overnight for one night, and then I send them home if everything looks good. It typically does, and I leave a stent in for 2 weeks. No lifting, over something like 15 pounds for about 2 weeks or so. And the main thing is just looking at the color of the urine, and if you have blood in the urine, to take it easy, and when the urine clears, then you can kind of resume normal activity. This is what it looks like during the procedure. So this is that straw that I talked about, and this is the patient's back, directly into the kidney, and that's just a safety wire. But that's the straw that I'm ultimately trying to get into the kidney through the use of wires and a needle and a balloon. And when this is in position, this communicates directly with the kidney where the urine resides. This is what the instrument looks like. The lithoclast is the name of it. This is like a little jackhammer. It's got a little tip that when I hit the pedal, it literally vibrates and breaks up stones quite well. But this is what it looks like on the television screen. The scope has a camera on the end, and then through that scope I can pass that little jackhammer, and this is the jackhammer right here. And this is all stone right in the kidney. So in conclusion, kidney stones are common and the incidence is increasing, unfortunately. Prevention is the key, but requires a long-term commitment. Treatment involves 4 different options: the trial of passage or observation, ureteroscopy, shockwave lithotripsy, and percutaneous nephrolithotomy. Thanks.